Welcome to MedAxiom HeartTalk, where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
Hi, I'm Melanie Lawson, host of MedAxiom HeartTalk, and today we are talking about how to navigate the complex 2026 CV surgery bundled payment model. And joining us today, we have two experts to discuss this. We have Ginger Biesbrock, Executive Vice President of Care Transformation Services here at MedAxiom, and also Nicole Knight, Executive Vice President of Revenue Cycle Solutions and Care Transformation Services, also at MedAxiom. Thank you, ladies. Always good to talk with you because you have such knowledge and you break it down in ways that we all can understand it. So Nicole, let me ask you the first question. Can you start off by telling us a bit more about the new episode payment model being rolled out in 2026, the Team Medicare model, and specifically the update to the CABG episode payment?
Yes, so this is a model that CMS is rolling out. Many of our organizations participated in bundled payment episodes previously. So Team is the new bundled payment that's coming out for 26 for CABG. And this is a model for traditional Medicare patients that participate in Part A and Part B. And it is looking at their CABG episode for pre-surgical and then post 30 days after.
Why is this really a significant change for cardiologists and CV practices?
Right. So the current model is CABG in this particular instance is paid out at a DRG, which is just the hospitalization. So the care wrapped up in the hospitalization, CMS provides a single payment. And then all the care that happens in the following 30 days is basically billed and reimbursed to each individual. And not really measured from a who's responsible for providing that care and assuring that it's not only high quality, but that it's efficient care, that we're managing our patients the most appropriate way. Still getting the high outcomes or top outcomes, but we're managing them in the most efficient, going to the right subacute or the right post-procedure, or assuring that they have good support on the back end so we can avoid readmissions. And so in the current model, it's really just each layer is reimbursed based on the services that they're providing. And this new model, it's taking this 30-day episode. Now, all the different places where the services are rendered will still receive payment. But what CMS is saying is we want the hospital system where that CABG was rendered to be responsible for that care and the dollars that are spent in that care for the next 30 days. So they're creating a target price based on that patient, and Nicole can explain more about that, but they're doing it in such a way to say, if you can do a better job than that and assure that that patient receives appropriate care but not too much care, in other words, if they can go home, let them go home. If we can better manage them, then we will actually give you an incentive. If you don't do a good job of managing that care and the patient ends up with some what they would consider unnecessary services and the cost of care exceeds that target, there's a penalty associated. So in essence, in summary, what they're doing is they're trying to force that initial hospitalization provider team to own the care of the patient for the next 30 days.
It sounds to me, and Nicole, I don't know if you can touch on this, but maybe some accountability as well.
Oh, yes, absolutely. And I think, like Ginger said, that target price, they're looking at what normally goes into that 90 days for that global period of that CABG, which includes that pre and post. What does that normally look like? What's that target price and reimbursement? And then if you're coming in at a higher reimbursement, if your length of stay is longer, the resources, the time it takes to manage that patient and the cost to the system, you're going to get penalized for that. And then they're also including quality measures in that. So when they do the calculation, not only are they going to look like what you were reimbursed during that episode, did it meet the target price, and then what were the quality metrics related to that? And then that determines if you get a payment or a penalty.
Do you think this will allow patients to be served better?
That's the goal.
Yeah.
So I believe so, because when you look at a post procedure episode for a patient with CABG? Are they able to send them home appropriately, or we tend to be higher utilizers of a post-hospital rehab where patients are going to a rehab facility? Are we doing a good job of, if patients have a question or concern, and we get them back into our office quickly? Those are the sorts of things and very deliberate decisions that if we make them well, we actually provide better care for our patients, and we're using less services for our patients. So if I can avoid an ED visit because I could answer my phone in the clinic and take care of that patient and get them in to be seen that day, and maybe in these cases, sometimes they get a little bit of an effusion and they need a tap to that, you don't have to go through an ED to get that. We just have to have ourselves set up appropriately to manage those things. So the idea is that they're going to incentivize your ability to better manage those patients in a lower cost setting of care.
Okay. Does have to be set up appropriately, or
Yes.
that's really important on that front end.
Yep.
So what are some key care delivery components of CABG care that could both improve patient outcomes and then kind of lower those overall costs, which I feel like you kind of have delved into?
Yeah, I think a lot of it is your accessibility for patients after they go home. If they have questions, they start to get symptoms, and your ability to evaluate them quickly versus sending them to the ER. Cardiac rehab is an extremely important. We've got a lot of literature that shows that patients post-CABG that go to cardiac rehab do quite a bit better than patients that don't. And plus there's a lot of support in that model for those patients. So I think a lot of it's just related to appropriate follow-up and accessibility for those patients.
Yeah, and I would add too that I think it's about access for our patients too, because it starts when that decision is made and that patient's in the hospital. So for instance, if patient has a heart cath because they came in with a STEMI and then they need to go to CABG and they're not able to be intervened on, they could potentially sit around and wait for a surgical procedure due to the availability of the OR, due to the physician's schedule, due to all these things. But this begins to measure all that time. So even in the pre, Ginger talks, the post is definitely where that large expense occurs. But I do believe they're looking at that pre as well because of the delays that it takes to get that patient to the actual procedure and the surgery. And that's a cost too, because they're taking up a bed, they're sitting in the hospital waiting for that care. So how do you operationalize yourselves to be able to service that patient quicker and safely and have good quality measures from them not having a length of stay?
Does sound a little overwhelming though. It might feel a little daunting.
Yes.
So is there a good way to maybe implement this so it doesn't feel so heavy?
So I think you start with getting all the key stakeholders together: cardiology, the surgeons, the post-op or post-procedure, the cardiac rehab team, the clinic team, and the hospital team, and what happens in the hospital stay as well. And just start to talk about your processes, talk about the work and the patient flow throughout those different stages. You could break that into really 3 components. You could look at your pre-procedural piece, you could look at the peri-procedural piece, and the post-procedure and post-hospital piece. And look for ways that right now you either have redundancy or things are slowed down. We have bottlenecks or access issues, or just areas where we know that because we're not set up appropriately, our patients end up at a higher cost of care. The other piece of that is to understand where those opportunities might be, is to get your hands, look at your quality data, your STS data will show you where maybe some of your complication rates are. We'll show you your length of stay. We'll even show you your disposition as far as where those patients are going after, and it will benchmark you against other organizations to show you where you might have opportunity where maybe you don't perform as high. You can look at cost data. And so many of our organizations are maybe involved in an ACO or a Medicare Shared Savings Program. They're providing those episode cost data already. It's the term is called a shadow bundle, and they're providing that level of detail on your patients. You just have to go find that information within your system. So I think you get the right people, you pull in the data that shows you how you're performing in those different areas, and then you just find where are those low-hanging fruit. Maybe even do these are the things I should just do right now. These are the things we have an opportunity, but they're a little bit bigger lift. Let's create a plan for that. But I think you just break it into bite-sized pieces. And the biggest thing is to get the right people together that can actually influence and make the changes necessary.
Yeah, execute. All right. Well, thank you, Ginger. Nicole, good information.
Yes.
As always, thank you so much for talking with us today.
Thank
Thank you.